Hello, everyone.
Hello.
Hi. Well, I see 12 participants in now, Isabel. Do you think this is everyone?
Yes, that's everyone right now.
Grand. Good afternoon, everybody, on what feels like to me a spring day in Oregon, but hey, we'll take it. Thanks for spending some time today and bringing your brains and your hearts to this work for Operations Committee. Isabel, will you help us with a roll call for attendance?
Yes. Bruce Goldberg is on leave. Judy Richardson.
I'm here.
Thank you. Mike Leahy. Mike.
Here.
Thank you, Mike.
Yeah.
Laura Byerly. I don't see Laura yet. Doug Flo. Don't see Doug yet. Sarah Fouché.
I'm here.
Thank you. Lori Hoagland.
Present.
Thank you. Michael Horry. I don't see Doris Carago.
Here.
Thank you. Anne Lovejoy.
Here.
Thank you. Paula Weldon.
Here.
Thank you. That's everyone.
Excellent. Thanks, friends. So, on the agenda today, take a look. Here's our agenda for this afternoon. Bit busy, bit full, but I have full confidence we'll get through it and get some important work done. We're going to touch base with our executive director, McDonald, about committee and board updates and our previous meeting follow up. We're going to launch into the administrative structure and hear from our consultants at Milliman. We'll discuss designating regions, and our policy advisor, Lee Hastings, will take us through that. We'll take a little break around 2:30. Then we'll launch into agenda item number 5, subrogation. Also, policy advisor Hastings will take us through that as well. We'll have a discussion and a decision to be made about eligibility and enrollment. This is a continuation of the conversation we have been having. Take a pause for committee member reflections, next steps, and hear public comment. I will insert in the agenda public comment about items we will be making decisions or voting on as soon as we complete the agenda review. Any additions, objections, or concerns with the agenda? Let's proceed. Did I miss any announcements, Mimi, that we needed to make?
I don't think so. I think we are going to turn it over to Isabel to see about public comment on voting topics.
Perfect.
Yes. We do have 2 people signed up for voting public comment today. I see one of them is here today, and if the other person joins, we can I can let you know, Judy, and we can give them the opportunity to speak. But as always, the board is really and the committees are really appreciative of members of the public who are able to provide public comment. It's really valuable. Written public comment, I don't believe there was any for this meeting, but I can double check. Would be posted on the website with the meeting materials, and for those can be submitted 48 hours in advance of the meetings, and for spoken public comment, those can be submitted 24 hours in advance of the meetings, also via our website. And today we have give people the opportunity to provide public comment specifically on voting topics before the vote occurs. So Judy, if you want to kind of go over the voting topics for today.
Sure. There are 2 voting topics today. One will be around designing regions, and the other one around eligibility and enrollment. So when you begin speaking, please indicate which agenda item you are speaking to help the committee focus.
Thank you. And with that, I will turn it over to Lou to give your public comment, and please let us know which topic you're speaking about.
Yeah, hi. Before I get started, Judy, I cannot hear you. I can hear everybody else, I think, but I can't hear you. The topic I wanted to talk about was regions, how to set up regions. Shall I go ahead and talk about that?
Yes, please. Thank you, Lou.
Okay. There were 3 levels, and I don't remember them all right now, but my concern about regions is increasing administrative expenses. While I do recognize the law calls for regions and specifically to get public feedback, I think we don't want to go to a brick and mortar type of situation that will be even more expensive. We want to keep this at less costly as possible, but get as much feedback as possible. I want to remind the subcommittee here and the board, and I've sent out a written document on including this, that all the information, every process or procedure that's going to be done will go to a central location to be paid. Therefore, the administrators of the plan will be able to see exactly what's going on in every city, in every with every patient, with every provider, etc. And with that ability, we'll be able to see where things are not going right or need help, etc., etc. So I would encourage you to approve the least expensive and way of getting feedback. The other complaint I have about regions is that my written example is that I live in Elmira, Oregon, which is approximately 20 miles outside of Eugene. Now, you would not think that that would be a rural area, but it is a rural area, and it has rural attitudes and feelings. So cutting up in regions, it's going to cause problems. Why not set up feedback systems and meetings that in any location you want in the future? So that's my input. Sorry, I went 18 seconds over.
It's a-okay. Thank you, Lou, for your thoughts. I'm sure we will discuss those when we get to item agenda number 4. And I hope that you can stay on and watch the presentation by Milliman, because they definitely talk about cost. Do we have the second?
Thank you. I can hear you now.
We do not have
Okay.
the person. I will send you a note if we do.
No worries. Director McDonald, will you lead us through committee updates, etc.?
Absolutely. Good afternoon, everyone. I'm Mimi McDonald, Executive Director of the Universal Health Plan Governance Board, and I'm going to go over some of the activities that have been happening at the board level and also at the other committees. So, the Operations Committee has actually met twice without a board meeting in the middle, but I will just give a brief recap of what the board has been doing. So as I mentioned at the last board meeting, they approved a mission statement. They updated the communications policy. There was a discussion around administrative structure and regional roles. So not quite the same discussion as what's going to be happening later today, but sort of a preliminary discussion based on the feedback that they've gotten from this committee. And then also there were multiple preliminary proposals that went in front of the board and which were passed regarding hospital payment quality. I would say the revenue proposal is still in a very iterative process. You will see that on the board agenda probably monthly until the final report is submitted. Speaking of revenue, finance and revenue still hard at work on the revenue strategy, again, taking feedback from the board and from the public and the committee members themselves about the revenue strategy. So there is a finance and revenue meeting at the beginning of January is our very next one, where again, things will really be firming up. And once again, at the last meeting, they also went over startup costs related to the reserves that are required for funding a health plan. Land design and expenditure, really the majority of that past meeting, our Milliman consultant group gave a great estimate of total cost of the health plan expenditures if a universal health plan were implemented in the way that we have described to date. So in other words, with that structure of all people being eligible, all people who live in Oregon, and having that level of benefits of what we've described as PEB, or the Public Employee Benefit Board level of benefits, and we're calling it PEB Plus because certainly all the people who are eligible for Medicaid would also be eligible for those additional benefits that are required. Also, however, on the plan design and expenditure meeting, and this is another topic that's going to continue to come up, was the discussion around cost containment. So looking at the different types of, we're calling them levers or areas where costs can be contained. We know a universal health plan has lots of administrative efficiencies, which will help keep costs down, but that will not be sufficient to be able to keep healthcare affordable in Oregon. And then lastly, our community engagement and communications committee and team are hard at work, mostly working around preparations for these targeted engagement meetings. And you'll hear more about that as time goes on. There will be website updates. We were hoping to get some of them done in December, but those have been postponed a little bit until January. I have their committee meeting paused, but it's not really a pause. There will be a CECC meeting again in January. Won't be one in February because of other commitments, and then they'll be back on the bandwagon in March. So I'll just say some breaks in the continuity of the meetings, but the work is continuing throughout all that time. So I'll stop there and see if anyone has any questions or if any of our folks wanted to add anything to that. Okay, next slide. All right, so just a little bit of follow-up and some teasers. So went over primary care and behavioral health operations at our last meeting, and then we will be following up again on that topic in January. Follow up around the eligibility and particularly around sort of the operations around eligibility and enrollment. That follow-up is again today, and as mentioned, we'll bring Lee Hastings is bringing sort of the proposals in a way that we believe will enable this committee to make some choices about what they would like to recommend to the board. People had questions around PEB and OEB, and so with this meeting's materials, I attached that great meeting presentation that our colleagues at PEB and OEB presented around operations. So that's available. The other thing is that I talked with the PEB and OEB people, people of this committee were interested in what the benefit level is. And actually that is public information. You can go on their website and see what is available. So I just wanted to bring that out. And then there were other conversations around workers' compensation and safe corporation and other types of subrogation. And again, that's what you get to hear about today. So happy to, I think it's gonna be really exciting and informative meeting. Alrighty, and I think that's it for me. Oops, I think you're on mute, Judy.
Thank you. Pulling up my agenda again, I think now we move to Milliman's presentation.
All right.
Thank you.
Let me get this up. Hello, everybody. Good to see you again. Okay. All right. Does this look like the right screen?
It does, and it looks great.
Okay, hi everyone. Glad to be here again from Milliman. You should have received a pre-read, and we have some additional information to share with you on staffing estimates and cost as well. So we will go ahead and dive in. If you do not remember all of us, here is your healthcare management consulting team at Milliman working on the administrative and operations components of the engagement. I am Kate Shadle, joined by my colleagues Caitlin Shoei, John Casey, and Stephanie Ross. We are all four of us working in conjunction with Fritz Bush and Ken Laskowski as well on their piece that they're doing for plan design and expense. And so happy to share just a recap of what our project approach is. So at a high level, we started here with you all just engaging in some strategic conversations around goals and success metrics for operating the UHP. Part of this presentation is we started by designing that organizational structure for key leadership positions, departments, reporting structures. You'll see that today. We are open to suggestions and conversations around that, what feels good, what feels right. We took that original organizational structure. We met with Mimi and Judy and Isabel and Lee and walked them through that, and have sort of changed and adapted based on that, but look forward to a good conversation again today with all of you. Based on that, we developed sort of more roles and systems, operational demands, and then used that to develop some administrative cost estimates and staffing estimates, which you will see today. So we are near the end of that arrow in our engagement, and then once we have some sign off from all of you, we will start writing a final report for you all. Right. I'm going to walk you through our organizational structure option. I'll turn it over to my colleague John to walk you through the staffing and cost estimates later. But just to start us off here, I wanted to start us off with this high level organizational structure. I think it sort of grounds you in sort of what a typical health plan organizational structure looks like, and has sort of these major functional areas. It's how responsibilities are typically distributed across a plan. I'll walk you through this, and then on the next slide, you'll be able to see how we've sort of adjusted that for the UHP specifically. So just to begin, sort of those 5 big dark blue buckets at the top, we've got our operations team. That is sort of that core engine of the health plan. It's handling provider network management, member services claims, and then sort of that sales marketing there. We also have an administrative team, generally led by a chief administrative officer. They're providing that infrastructure to enable the health plan. It includes that legal oversight, HR and talent development, compliance, facilities management, and more. We next move on to finance, led by a chief financial officer that oversees actuarial services for a plan, financial planning, accounting, those treasury functions, and sort of any of the sort of stewardship of plan resources and looking at fraud, waste, and abuse. That 4th category you'll see is the information technology, led by a chief information or technology officer. That's going to support all of your data-driven operations, analytics, the IT infrastructure you'll need to run the plan. And you can see sort of all the typical pieces here. There are a lot. You'll still need all of those throughout your UHP. And then lastly, you'll see medical management, typically run by a chief medical officer, focusing really on that clinical quality, utilization management, care management, behavioral health, and pharmacy. And again, this is a typical health plan organizational chart. And so we used this as a baseline to see what is typically included. And then we next look at a lot of research of universal health plans that are around the world, single payer plans, and said, what's missing? What might Oregon be interested? We looked back at all of the operations committee meetings that you've had. We listened to all of the board meetings before we were onboarded, just to see what the discussions have been. And we came up with this next slide here. So there is a key in the top corner. You will see anything in that sort of light green is the same as that traditional staffing model. Anything in purple has been adapted or added as a new role for the universal health plan. And then anything in that dark green is traditionally outsourced as part of the plan. This does not mean you have to do that. It does not mean anything in light green is not outsourced. This is all really up for discussion as you sort of finalize what the plan details look like. So I will walk you through this, and then I will pause and we can discuss. Of course, you'll see at the top, this will be led by a public corporation, board of directors, president, CEO, executive director, whatever language you end up deciding on. And sort of in that operations bucket, we've kept all of the same positions. And instead of having a marketing sales position, we've changed it to marketing and communications. It will probably be less of a sales marketing intensive role, but we still feel like based on rolling out a universal health plan, getting everyone on the plan, there will still be a fair amount of communications involved, a fair amount that is still important on that community partnerships and community engagement. There's a committee working on it right now. I think that will continue as you start to roll out the plan. And so we wanted to leave that in there and just shift it a little bit away from marketing sales and more toward that communication piece. The biggest change in the organizational chart you'll see is in the administration column. And so while we've kept a lot of those same functions under Chief Administrative Officer, we've added a whole column that is under what we've called a Chief Strategy Officer. And this is where we have brought in a lot of the things I've learned from watching past videos. We know that policy and ties to policy will be important, especially as you're working to coordinate federal waivers. And we've added in a lot of those public health components that will be really key in making this a success. Some of those quality and performance, as well as evaluation and research that will be important to the state. And then coordination with the public health offices, local public health, Oregon Health Authority, thinking about keeping that health equity and inclusion lens to make sure there is access, language access, cultural competency, and more. And then thinking about, lastly, sort of that health system integration and innovation and how all of these pieces will work together is going to be so important. You're going to have your health systems, your local public health, you're going to be integrating in behavioral health, dental, vision, new pieces. And so we just wanted to include a spot there where Summit is focusing specifically on integrating all of those systems together. You will also see a new role under that Chief Administrative Officer specific to privacy, state data compliance. We think that will be really important as we're pulling in all these health records into one plan. And so that's an important key position here. As we move to finance, we've added in audit and financial compliance. We think this will also be important as ensuring there's some transparency and monitoring of expenditures as you move forward. Everything here you'll see stayed the same in information technology. I know when we had a conversation with Mimi and Judy, it was like, is everything there? Everything is there. It is a big role. We are not discounting the impact that we will have a high need for information technology. Those roles are all there, and we've accounted for them in our model as well. And then lastly, over in medical management, we've added a couple pieces here around health informatics and analytics and population health, just thinking about from a medical standpoint, some of that utilization, forecasting, and outcomes, which will be important as the plan sort of grows, and then addressing some of those social determinants of health from that medical management lens. You will also see here, we took out that traditional PBM language, but included the fact that you'll think about how to connect alongside pharmacy, behavioral health, vision, and dental. So those are all in there. And then lastly, that Chief Strategy Officer, I also envision them overseeing the regional teams, which we just have. I told them I love a good acronym, so I call them Health Integration Teams, or the HITS. And so those are there, which we'll see on the next slide. I know, Mike, you've got a hand raised. All of this to say is that this potential organizational structure is based on the conversations we've had with you. It is based on the things that we have learned and the work you have already put in. This structure, the future of this structure, it could change based on sort of where the final benefit design lands. And we are willing to sort of work with you in changing and shifting this as you see fit. But I will stop there and I'll turn it over to Mike. I know you've got your hand raised.
Thank you, Kate. Can you hear me?
I can.
Great. Well, thank you very much. I'm the newest member of this committee and newest member of the board.
Welcome.
But I'm reflecting on, a gazillion years ago, I spent about 5 years as Kaiser's health plan manager here in the Northwest. And I'm just noting which things an organization like Kaiser classically has to compare to this. First of all, this is an excellent initial frame. So thank you so much for doing this. One of the things that at least I remember is that when there were basically four major functions under the health plan. One was the marketing, one was essentially all the contracts and a member and other information stuff, some of which would apply for us, some won't. The third was all the kind of public affair piece and the relationships to government. And the fourth was legal and risk management. And something for us to consider is maybe we should somehow more appropriately or put risk management up on a higher level. The second comment I have is regarding the IT. It occurs to me that it's necessary for us to come up with an IT strategy, but I don't think that will be sufficient for the universal health plan. We really have to have some interaction with a larger IT structure. Now, fortunately, we're in a state where we have things, the dominant software provider is Epic. So there are some things going for us, but I think we have a little work to do to think through the information technology area, if you will, and this is basically an architecture issue. And my third piece, and this is one of the practical complications. I know that within Kaiser there are corporations, for instance, we would deal with that were not Northwest corporations; they were national corporations. So, for instance, I happened to be the account executive for Nordstrom and Nike and Microsoft and Boeing that are in multiple regions. And so at some point, either today or maybe in a January meeting, you could help us think through all the other capacities the organizational structure will have when in fact we're dealing with organizations that have people in multiple states, and yet we're only talking about coverage for ours. So I think there's another, not big, but another small chunk of work that would need to be added to this structure. And that said, you don't need to incorporate any of my comments here, because I think this is certainly a wonderful frame for others to start commenting on. So thank you.
Absolutely. Thank you for the comments, and our whole team's on, and so we'll take all of those and look again at our structure, and happy to discuss with you again. Any other comments, reactions? I know you're a talkative group, so.
Thanks, Kate. I see Doug.
Perfect.
Hi.
Hi, Doug.
Just a limited comment, and that is that I'm assuming that there's a relationship between the chief medical officer area and credentialing. There needs to be, if there isn't. That's a very touchy area, as you know.
Yep.
Yeah.
And that he or she needs to have their fingers in that pie. So.
Yeah, so I'll just take that one real quick. This is John Casey. We typically see that as a function of making sure that the network is properly credentialed. So that's why you see it sitting over there with the network development in the network area. However, yes, the chief medical officer does need to have oversight of that, as well as other areas. They have their hand in a number of different areas as well, related to compliance, even customer service, claims, so that role, that chief medical officer, and what's going on over there in the medical management bucket, is not a siloed thing. And actually, all of these pieces should be working together at some level. And there's going to be some, the classic way that health plans deal with all this is there's committees, of course, within the health plans, and there's different oversight within those committees, just like you all have here. And so that's kind of how we would expect that to work. Great comment, Doug. Yeah.
Thank you.
Yep.
I love it. What else? Anne, go for it.
Yeah, I just want to say that I like what you've done with the chief strategy officer. The particular responsibilities under that sometimes get submerged under other areas. And I think this assures that there'll be quality and really high value for the consumers.
Yeah, thank you. I come from a public health background, so that's always important to me, is make sure it's not sort of swept under medical management or another category. It's a big thing y'all are doing, so we want to make sure it's got people dedicated toward that. All right, anything else? Lori.
So this is a fluid situation in terms of I know this is not what we're tasked with specifically today, but as you move forward with what claims are accepted and what are not, I'm just trying to wrap my head around where that decision making would be going on. What is the plan going to cover, and how, I guess that would be involving operations, medical management, a number of different groups discussing. But I'm just, as the plan evolves, medical recommendations evolve, the role of algorithms, approaches to different issues in healthcare.
Mimi, I see your hands raised if you want to jump in.
Yeah, I think that's such a great call out, Lori. I know sometimes it's just referred to as plan design, like which it wouldn't really be design, because that, I mean, the ultimate area would be kind of directly under the board of directors. But I think that's a great call out, Lori, and that because of course, just like everything else, it'll be an iterative process and things will change over time. So having that plan design and benefits sort of called out, is that, does that fall under policy, under the chief strategy officer? Is it in medical management? That's a great thought.
Thank you. Anne.
Hi, I have a follow-on question to that. Most of the insurance companies use algorithms or auto adjudication, so most of the claims get paid kind of based on technology, which of course makes a difference in vendor selection for information technology hardware. Is that part of plan design, or is that part of operations to actually, or is that Millman's role to do the RFPs for that kind of work?
So I can take this one. It's not our role. We'd be happy to help you with that in the future, but that is not part of the work we're doing here now. So what we've all designed here and what we're looking at here is an idea based on what we've heard your discussion so far. There are still lots of undecided pieces about what would be insourced and what would be outsourced, for one. So very frequently we see claims systems, those kinds of things are purchased instead of built, they're bought. But for a plan, for instance, of your size, for what this would be, you would almost certainly operate most of that core system, is what we would call that, in-house. You would have scale to do that, essentially. Now, there would still be people operating that technology. There would be less people because there's efficiencies of scale, especially in claims. And like you're talking about, like there's a lot of technology going on there for sure. And there are certain vendors in the industry, if you wanted to look to purchase a system, which is probably what you'd end up doing, is purchasing a core system. But there are certain ones in the industry that are better at dealing with diverse populations like you would be dealing with than others. But if you were to go out to do that, yeah, it would be an RFP, I would assume. And we can help with that. There's other firms that can help with that as well. But you all would have to make the decision that that's the right thing to do. And we can also help you make that decision. That's a different set of work.
Thank you. Thank you.
Yep.
Well, I'm going to keep moving on because I know we're going to have a lot of discussion on the next slide. Hopefully Lou is still on. I know you had asked about regional teams. So what I'm going to show you next is a proposed structure on regional teams. So what we did at Milliman was take this sort of background information that Lee had done and wrote into the straw proposal on regional teams and said, maybe we'll have around 5 to 7. And the functions that we want in the regional teams are these 6: provider education, workforce development, member outreach, community engagement, local innovation, and health resource planning and prioritization. So me personally, I like to react to something rather than just imagine in my mind what it might be. And so I've provided sort of 3 different scenarios here, and they are very fluid. You do not have to choose one and that's the final one, but I wanted to put some options in front of you. And so what I've done here is start with the lowest level of regional team autonomy, is what I'm calling it, where there is just simply some regional coordination and structure to the Universal Health Plan. This would start with a relatively small team, maybe have a regional coordinator in all of those regions, as well as a community advisory council, or maybe it is truly made up of volunteers from the community. Maybe that's some health systems, some regional local public health systems, maybe some nonprofits or community-based organizations. So that core team would be relatively small in this model, maybe just 2 to 4 staff, someone who's thinking about those first 2 buckets, work provider education and workforce development, someone who is thinking really about the next 2 buckets at the top, the member outreach and community engagement, and then maybe someone who is looking a little bit more closely at the data specific to that region. And so this team might just focus really on provider education, helping identify some of those local workforce needs, thinking about how they are engaging specifically with their members and their communities as this plan rolls out, and then really reporting that local data up to the UHP board. Some of the pros of this approach is to start, it's just less resource intensive. They're smaller teams. It at least establishes a local presence in each region, and there is a real feedback loop to the centralized plan. Potential cons here are that there is limited local authority. We're not asking them to do any resource allocation here. We're not having them act on any of those workforce needs. This is a very minimal staffing, and so just sort of establishing what that regional team may look like in this model. This central model here is what I've called regional partnership model. This has just a little bit more structure to it, where you might have a regional director leading alongside a community partnership or community advisory council. Same thing, but that community partnership board, maybe those board members are provided a stipend, so there's a little bit more sort of investment in this team when they're leading it. The core team is maybe around 5 to 7 staff per region. They're focused on both the provider education as well as workforce development, but in 2 separate roles. I've left that same member and community engagement coordinator here, the same data analyst here, but I've added specifically a health resource planner. And this might allow this team to focus a little bit more on piloting some local innovation and workforce improvements, helping sort of connect all of those community-based services, integrating health and social services a bit more at the local level, and really doing some more data sharing and quality improvement projects. And so if you think about some pros here, it builds that shared accountability in each region between that regional director and, if there is a partnership board being paid for that position, there's a little bit more collaboration here. And some of those community partnerships could really buy in to help enable some of those public health changes that will ultimately impact maybe some health outcomes in the long term. It would require a little bit more governance and oversight, a little bit more resources for staffing here. You could really start to see some variation in quality depending on the engagement of that local partnership model. And that sort of really this middle has some autonomy, is a little bit more staffing than that first model. And then lastly, I've put in a team with a lot more autonomy in what I'm calling the regional operations model. This would be led by maybe a regional executive director and a community advisory council that also is paid here. The core team might be a little bit larger with about 8 to 10 staff. That includes a provider engagement and education manager, that workforce development coordinator, same as the middle model, a member and community engagement coordinator, a health resource planning and data analyst, but includes maybe potentially some more support and administrative staff and someone thinking more about operations. This model might focus more on local contracting and workforce, especially potentially in that behavioral health field, thinking about health resource planning and prioritization, and doing a lot more quality improvement here. The pros is there is a lot of local ownership in this model, potentially with more people invested in larger teams and with more autonomy. They might be a little bit more responsive to health issues as they see them coming in, have more ability to sort of make changes quickly. As a con, as you can imagine, it's more administrative infrastructure and would require more oversight and alignment with the Universal Health Plan and oversight. That being said, all of these are flexible. You don't have to choose one or the other. And note that the staffing sizes may change depending on how the sort of regions shake out, how many population are served by each regional model. There might be a larger team in near the capital city. There might be smaller teams in rural areas. And so this is all very flexible. We have included in our staffing and costs what these regional teams might be included already. And so to Lou's point, small teams, but not anything that will change the budget and the scope of this really large plan. I'll stop there. I am open to feedback. These are just to put something in front of you and start thinking about what this could look like. And would love to hear any feedback you might have.
I've seen this presentation a number of times, so I want to reserve and give the committee space to offer feedback and comments. But I will say that I really like that the feature of this, that it can be customizable and adjusted right size depending on the region of Oregon. That feels like a very Oregonian thing, where different sections and regions of the state feel very unique. Certainly would say so if you asked them.
Yeah, absolutely. Thanks, Judy. Lori.
So I would agree with Judy's comment. I think that, different size populations and metropolitan versus rural would fit differently in these different categories. But I also think the one thing that concerns me is the relationship between employers, and the transition from what we currently have to where we're going. Obviously, if we want this to be successful and we want to have at least adequate interface between the businesses that are employing the healthcare workers, and having a health plan that is the same quality level across the state, and having perhaps a different workforce in each area. There's a lot of pieces to kind of take charge of. So I just wanted to mention that, yes, we want it to be affordable, but we also want to be prepared to address issues as they come up in this whole new universe.
Absolutely. Yes. And to Judy's point, I mean, not only are these customizable, you could really start with a small team in the regional coordination model, and that might change over time. That you could realize the benefit of having them and say, here's what we could really add on to them. Here's what might change. This could develop as you roll out the universal health plan as well. Anyone else? If not, you've made my job on this.
Fire away, Doug. Go ahead. We've got one more, Kate.
Can you hear
Okay,
me?
perfect. Yes.
I just want to second what Kate just said, and that is, I think there's some real value of considering starting small and learning from those first steps before you get anything more complicated on the ground. That comes from a lot of experience. So
yeah, absolutely. Thanks, Doug. Sarah, go for it.
Whoops, I'm gonna need to. I have my phone as well. Can you hear me fine?
Yes, we can.
Okay. Was juggling phone and computer. Yes, I'm initially more drawn to the less autonomous models on the left, the coordination model and the partnership model. And I'm wondering whether I have a bias, having mostly lived in big cities or the capital city of a province or state, or within the largest city or second largest city in a state or a province. And I'm wondering if on our meeting today, we have people who have had a different living experience, maybe a more rural living experience than myself. And I'm wondering curious whether my bias is kind of like a big city or city person bias. So I'm just curious about that.
There. Anyone in the rural areas that would love to respond? Yeah, Lori, go for it.
Well, I think about circumstances which has actually occurred in the state where you may have the only primary care clinic in a rural area suddenly go out of business and create an incredible vacuum in that area. And then if you had a local infrastructure, it may be easier to troubleshoot the situation than if you have someone in a central location, like imagining perhaps Portland going, meeting up with people in an area that are a very different culture, different expectations, different view of the world in general. And I think that the regional folks may be in a better position to troubleshoot crises.
I would agree with Lori on that comment.
Yeah. Okay. Great. All right. Well, thank you for the discussion. In the interest of time, I will move on and pass it over to John, who will walk you through our estimated staffing and administrative costs. Over to John.
Okay. So now I'm going to show you some pretty big numbers and we'll talk through those, but first we're gonna have a little bit of setup. So if we can go to the next slide. The first couple slides we have here, I'm not trying to bury the lead, but they're pretty important because I wanted to help you understand how we came up with the values that we've come up with. And what we've come up with are estimated administrative staffing levels. So like numbers of hires, numbers of FTEs or full-time equivalents is what that means. And the administrative cost associated with running the plan. So not the benefit cost, but the administrative cost. And so we base that on a number of assumptions. And that's what you're finding here on these first slides. So really the first one being the population that's going to be served and how complex that population is. So it matters that the people that are going to be populating your future plan, yes, they're all going to be under one umbrella eventually. But what we know and what our historical data tells us in our benchmarks is that, for instance, as an example, a Medicare member, of which you have roughly 828,000, is more complex and requires a lot more administrative cost to serve them appropriately than, let's say, a fully insured employer model, of which you have 929,000. So we take all of that information and we impute from the other half of our team who's developing the cost estimates, but we understand what the costs are for those members at a member level. And then we have benchmarks, which we're going to share, that we use that are based upon the complexity of that actual population. And so that's why this piece matters to us. All right, so our benchmarks are, this is something we do a lot of work on. We do this for health plans. We do it for public entities. We do it for state Medicaid agencies. But we spend a lot of time looking at historical data that we aggregate from hundreds of different TPA and plan-like organizations across the country. We do this on an annual basis. And we develop what we call baseline benchmarks for every line of business. And by a line of business, when I say that, I mean Medicare, Medicaid, commercial, so those different complexity levels. We develop baseline benchmarks and then we adjust them. We adjust them for a few different factors. One is what we call business mix. So what is the mix of that population? How many Medicaid members, how many Medicare members, how many commercial members? So that's one piece. Two, size. We know that if a plan is bigger, it's going to have greater efficiencies, usually. There are some areas where we get to a point where things become inefficient if they get really big. But usually, as plans get bigger, they gain more efficiencies. They get more fixed cost, which means, if they purchase one system to do one thing and they put more members through it, that is like your claim system you mentioned earlier, Anne, that is spreading out the cost among that claim system. Usually there isn't a whole bunch of incremental costs there. So we know that. Geographic cost. So where are the workers that are going to be operating the plan? Where are they located? If they're located in Kansas, they likely are going to cost less because they have a lower cost of living than, let's say, New York, for instance. And so we want to know that kind of thing. For this analysis, we have assumed Portland, Oregon, which we think is a conservative estimate. We know people could be other places, but that's big city, more expensive, higher cost of living. And then what we call the administrative model, which is really your benefit design. It's the decisions you make and it's the complexity of the environment in which you're going to operate. So we can go to the next slide, but these are kind of as a setup for what our benchmarks are. So we made a number of assumptions to do this. One is on the left-hand side of this slide, we assumed some efficiencies. We assume them in provider contracting, premium billing and reconciliation, coordination of benefits, sales and marketing, and corporate services. I'll go through those briefly here. So provider contracting, this future health plan is going to have to do less contracting activity. Right now, they have to establish contracts with lots of providers across lots of different lines of business. In the future, you're going to contract with every provider in the state or whomever wants to participate. And then there will still be, we want to acknowledge this though, there will still be some contracting activity with providers outside of the state, which you're going to have to understand and establish agreements with what happens on the border. And so we didn't cut all this out. There's going to be contracting activity. Two, the contracting department in a health plan is typically also an area where some of the kind of more value-based analytics comes out of. And so we left some money in there and some staffing in there in order to accommodate for that. Premium billing and reconciliation. Most of the member liability or the billing activity is going to go away. And so we greatly reduced or eliminated most of that activity. Coordination of benefits. Coordination of benefits refers to when a health plan has to deal with multiple payers or claims activity. So that would be if a health plan had a Medicare member and that member also had Medicaid. They were also Medicaid, so they were dual eligible. They have to coordinate those benefits, figure out which one pays first, which one pays second, and then get the claim right and then get it out the door. You aren't going to have to do as much of that. You're still going to have to do some because we assume there's not going to be able to, you're not going to be able to supplant every payer. For instance, TRICARE. We haven't discussed that, but you may not be able, that may not go away. There's also still going to be some activity on the borders of the state, but that was greatly reduced in our model. Sales and marketing, we already took care of. We talked about that earlier. Kate talked about that. And then corporate services, we assumed some greater efficiencies for plan size and simplification of the activities. From our model, we also excluded some costs at this point. We can talk about bringing them in at a different point, but our basic administrative model does not include costs for administering dental and vision services. It's a medical and pharmaceutical model. It does not include costs that would typically be borne and billed by a PBM. What the model does include is the cost to administer a PBM contract or to oversee that activity. So that is typically an outsourced activity, even for the largest health insurers. Even if they own their own, they're still paying that entity a separate fee for the members that is being served. And so that's excluded from our benchmarks. The cost to oversee that contract and manage it is included. Same with behavioral health, typically an outsourced activity that in our benchmarks is included to oversee that activity and manage it. A few additional assumptions. We use the enrollment and expense projections that that the other half of our team, which is led by Fritz Bush, is developing. And as those change, or if they change, it will change our values as well, because again, our values are tied to, they're dynamic with the assumptions about the complexity and the benefit design decisions you're making. We did incorporate some additional staffing needs for the regional teams and public policy health positions. However, I'll say that those are not substantial. You looked at the size of those teams, even at the largest team size, you will see on the next slides here, we're talking about some very large numbers here. And so it's not going to move the needle hugely one way or another. Those decisions are important from your operating structure, but it's not going to move the needle in a huge way on the expenses. And then the other important thing to note as we look at these numbers is they assume steady state operations and efficiencies. So we can talk about startup expenses, but those were out of scope for this work. And so we would assume, though, that the plan would be pretty inefficient when it first starts, and it would gain efficiency over a period of several years to get to a steady state operation. All right, let's go to the next slide. And I apologize if I'm rushing a little bit. I do have a hard stop at 5 o'clock. My other half of the team here will pick up where I leave off. And they'll field any questions back to me if we don't feel like we can answer them, but we'll get there. All right, so this is a staffing estimates. I'm not going to go through line by line, but essentially these are the areas that Kate talked about on the organizational design slides. Your staffing, we represent everything in ranges when we're talking about benchmarks. Benchmarks are directional. I will say this though, your staffing, we feel pretty confident that your staffing will be between somewhere around 11,500 people and 22,900. Now, it's a really big range. I get that. But that's also because there's a whole bunch of unknowns in here about what you want to outsource, what you want to insource, how heavily do you want to really staff your organization. I will say that our best estimate is that 15,000 in the middle, that 15,300. There is going to be variation, again, within on a line by line level as well here, that, you know, you're not going to hit the middle on every line. You're going to be, so if you decide to, let's say, staff up in IT and be on the higher end in IT, you may be on the lower end in operations because it may give you efficiencies in claims. So there's push and pull with all of these pieces depending on decisions that you're going to make. But the takeaway here is that really, you will likely be somewhere close to that 15,000 FTE number to operate your plan. Any questions or comments there? The next slide is money.
Let's do the next slide while we have you.
Okay. All right. So here's the big money slides. So again, variation on every line, your costs are going to vary somewhere. This is administrative cost. So it's not the cost to deliver the benefit. It's not the cost for the person to receive the benefit. It's the cost to administer it. In the health insurance industry, this is typically somewhere around 15% of the total cost. The other 85% is usually the cost of care. This is the 15% part. However, you can see down here at the bottom, the punchline is that you're likely going to be a lot more efficient than most plans. You're going to be somewhere between 4% of 4% of cost will be administrative, 4 to 7% will be administrative costs. That's in line with a lot of research we've done. It's in line with the assumptions we've made in our model. And it is also, we think it aligns with some of the initial assumptions you gave us, namely the removal of certain administrative functions or reduction of those, and the fact that you have no intention of creating margin in this program. So we know that you want to have risk-based capital and cover you have treasury function you need to satisfy, where you need to have enough money in the bank to administer the program, but you have no intention of making money on it. In the normal insurance industry, margins vary, but in a commercial health insurance industry, margins are usually somewhere for, let's say, a large group commercial plan for a large employer. The health insurance company is probably collecting somewhere, but it depends on the year, probably somewhere between 2 and 4% margin. That's excluded from this. And so you're going to find that efficiency as well. All right. Any questions before I apologize? I have to drop. I am sorry, but I am happy to take a question or two before I go, and the team can follow up as well. I know Kate's stuff is easier to ask questions about. Yes, Mimi.
Thank you so much for this. So grateful. One of the things I'm wondering about is if there is a further breakdown kind of within the operations or admin or thing of, I don't mean like specific job descriptions, but somewhere along those lines, some kind of way, if we're thinking about the things changing in a plan where we might be able to move things around, just exactly like you said about IT versus ops.
Yeah, that flow between those, if you were to make certain decisions about your IT structure, then we would maybe revise our assumptions here. Or I want to make sure I'm understanding your question. Or is your question, we have this context column over here that has a whole bunch of stuff listed in it. There's a bunch of stuff in ops. There's provider network management, member services, claims, marketing, communications. Or are you asking to break down those buckets? Because we could do that too.
Yeah, well, I was wondering if you did have that, if that was sort of part of it, if there was that further breakdown.
We haven't developed that
available.
We have those values. I will say this about benchmarks in general, especially so we're projecting out something that's never been done, and two, benchmarks always lose credibility the tighter you go with them. That being said, yeah, these are already pretty big benchmarks. So yeah, we could do that. Absolutely, Mimi. Just wanted to caveat that. But yeah.
Thank you.
Sarah.
Yes. I'm reading the footnote at the bottom, and I'm not understanding the use of the word premium in the final sentence. Administrative costs as a percentage of premium are expected to go down to a steady state.
So yeah, in your future, I guess you won't have premiums, but this is how we think about the percentages. So the 3.8% to the 7.1%, that's what that's representative of. So if we think about a total premium, if we were a large employer, we got the portion that our employees are probably paying a portion of it, and we're probably paying a portion of it. But let's say that a total, when we add it all together, is $100. That's the premium. And so the total cost for the plan per person per month, PM, that's what we think of as a premium. So we won't use the term premium anymore, but it's the monthly cost of the plan, essentially per member per month is what we're talking about there. All right, I apologize. I would love to take more questions because I love talking about this stuff, but I've got to go. So please ask the team more questions. They're very well versed in this, and it's been a pleasure meeting you all and chatting with you.
Thank you, John.
Thanks, John.
Thanks a lot.
Hi,
Go ahead,
go
Mike.
ahead.
Can you hear me?
We can hear you.
Okay, great. So my question is really less about, let me ask the question today, recognizing I think I want to park the question for a future meeting for us. One of the obvious concerns in change management when you go from one system to a very different system is the impact on people that are currently working in CCOs and health plans, et cetera. I think one of the things we will want Milliman to help us think through is, so how do we go from this, and how do we uh, transition? What kinds of educational and training and other experiences do we need to basically use many of the people that are currently working in the system, that they at least have some opportunities for employment? This is a major manpower planning issue. Years ago, I was involved in an effort by the Obama administration to move people from the auto industry who were being laid off into certain IT jobs, and this was in Michigan. But the same principle applies. If you have people that are likely to be less utilized or moved to part-time or whatever, there's a major opportunity to think through whether we're talking about 10,000 jobs or 15,000 jobs or whatever. This will, as a system, this will still be way more cost effective for Oregon Health. But we will have to think through the whole migration path between now and 2030 and 2035 as to how to basically use community colleges and other training sources to reskill people for the new world. They're right now skilled to maximally upcode and other kinds of games, and the new jobs will be quite different. So it's just a consideration for maybe a next meeting for us.
Mike, that's something we've talked about with Mimi quite a bit, because obviously this 15-ish thousand number, we are assuming exist quite in a lot of your existing infrastructure. So I think it's 15 CCOs, right? And then other health plans and other kind of plan employers across your state. So how do we think about change management over the next 5 years to prepare what's going to be needed, what currently exists, what is that gap, and then what is the impact from the disruption as well? So that's kind of what I would consider like phase 2 of this work as we start to think implementation. So this is the what, and then you're talking about how are we going to get there, and what is that disruption truly going to look like at a kind of macroeconomic level. And so it's definitely something we've talked about and are very aware of, but looking forward to hopefully keeping a lot of those people and leveraging the talent that currently exists in Oregon.
Great.
Sarah.
Yes, look, I'm glad you brought this slide up again. It's a bit of sticker shock to see, especially that right-hand column, the less efficient scenario, 12,000 people in operations, 1,100 people in administration. And I'm comparing the layout of this information to the slide where the operations was shown traditional model health plans versus our model. And the new slide with the purple headings broke things like very general terms like operations and administration into, for me, more digestible chunks with that communications role and the strategy role. And as this heads closer and closer to the more public eyes on it, instead of just seeing these huge numbers, operations 12,000, administration 1,100, if it was maybe broken into more than the 1, 2, 3, 4, 5 rows, to include maybe things like communications or strategy, it might be more palatable.
Yeah, absolutely. In the same way we have the breakdown of the cost, we have those kind of subcategories for staffing. I think it will be provided in a range in the same way, most likely, because to John's comment earlier, that interplay of the decisions that get made on how this gets implemented is going to then impact your FTE levels. You might need 100 less people in ops because you bought this software instead of that software for this one capability. And so as you get more and more granular, that's going to get a little bit tricky, but from just that next one click down, I'm sure we can provide that. And that will be in the report from kind of what we write up.
Lori has a comment.
The comment being that, and this may be more of a situation for the community engagement, is making an attempt to compare and contrast our current system with this system, because people are not aware of how much money and how many people go into our current system. And, you know, I think this looks shocking if you don't see that it's actually really good relative to what we're currently doing.
Thanks, Lori. I know Doug had, yep, I was going to say, Doug had his hand raised earlier. Go ahead.
Yes, I have a quick question. Has anybody attempted to do an assessment of the current comparable workforce? How big is it in the state of Oregon compared to the 15,300 we're looking at in our best estimate in the middle here?
Yeah, I know that Lee had done some sort of back of the envelope math when she started, and so
Good for you.
I don't know, Lee, if you want to talk about that or if those numbers have changed.
I haven't checked into changes on those numbers, but that was just based on kind of the approximate number of folks that are involved in this kind of work in Oregon as it stands now, whether through a health plan or on the provider side doing claims and IT and all of that. And these are all functions that under a single payer wouldn't have to exist in that fragmented sense, but would all come under the single corporate entity.
I apologize if I missed something, but what was the number?
If you give me maybe 60 seconds, I can find that, but I'll have to locate the folder.
I want to say it was around like 12,000.
Thank you.
Yeah, I could be a little bit off, but yeah, Sarah.
Yeah, I'd like to echo what Lori said about the importance of continuing to highlight. It's kind of hopefully some communications people are listening or whatnot, kind of a communications topic. But I feel we need to keep emphasizing the contrast between this and what we saw on that next slide about like I would love to see a footnote on every slide that talks about this kind of thing, contrasting to what private health plans administrative costs are, so that people, because all this was really a shock to me, this slide and the next slide, until I heard that all three columns are, you know, beating private health insurance by such huge margins.
Mm-hmm. Yeah, absolutely.
There's two efficiencies here, and one is comparing health plan to health plan. But actually, if I use my global health experience, the biggest efficiency isn't this. The biggest efficiency is, imagine you're in a medical group, and there are, pick a number, 20 doctors, whatever. I think people will be amazed at how many support staff there's needed in that particular medical group for the 20 doctors or the 20 providers. the being able to have one contract and one source of funds and no administrative gobbledygook is really where the savings are in other countries. So because we don't have great US experience about this, I think Milliman's doing a very reasonable job of projecting, but the biggest cost saving here is not this kind of administrative piece. It's how fewer people any medical group for any of you on the call anywhere around will need. And so there'll be fewer jobs there ultimately. And those are the people I was talking about before, that if they were trained in some new complementary skills, could be considered for the work in this, but still there'll be a tremendous net savings. Thank you.
Yeah, absolutely. And those are some of the operational efficiencies I know John talked about on this slide earlier, but you're absolutely right. Thanks, Doug. Or Mike, sorry. Lori.
And to further that conversation, the brick and mortar involved with the siloed insurance operations currently is a huge expense that people probably wouldn't even think about if it wasn't laid out.
So Mimi, just a quick question on that. I don't know what, so Milliman's been engaged from like a projecting universal health plan in the future, not from a what is currently existing in Oregon and how is that going to compare. Mimi, is that work underway? Is that something as we think about maybe a phase 2 of this engagement we'd be interested in? Because I'm hearing that as a theme among all of you, like, hey, this is really great to know what it needs to be, but how does that compare to current state so we know what the disruption is going to be?
Yeah. Well, I definitely will talk more with the team and chairs in the committee, but that type of work, which is more fact finding than analysis, is something that probably is more likely to be in the wheelhouse of the staff and with our state partners. We're also cheaper, you know, sorry. So that kind of work will probably more likely to be coming from us. So that's what I will say. There, we have plenty of work that we're just going to keep on you guys going until the very end. But I think that kind of stuff we can take care of.
Absolutely, I think that would be a great like precursor to then our work and report to set the context. Makes total sense to me though, Mimi.
Oh, I do have one, sorry, just for hopping in here, apologies. I do have one question. I'm wondering if it is possible, knowing the behavioral health, how behavioral health is a huge priority in Oregon, is there the potential, I know sort of that was extracted from the analysis, would it be easy or relatively easy to add that back in? Because I think that behavioral health is one of the things that we would be very highly unlikely to outsource. So I don't know if anyone else wants to hop in on that one.
So we can look at that. The reason, so we have the oversight of behavioral health included in our numbers and projections.
Yep.
We do not have the actual administration of it because of the differences of how behavioral health networks operate in behavioral health services in comparison to others. And so let me go back to the team and see what we can do. I don't know if we would ever embed it into the total, but we might be able to provide something as in like in addition on the side.
That would be, I think that would be great. And yes, we know it's incredibly complex. It's one of the things we hope to get better on.
Yeah.
Great.
Just in the interest of time, Lori, one more comment about this topic and then we'll switch gears.
Mine relates a little bit to that, just that conversation that we just had. You know, there is a lot of model changes with moving behavioral health into primary care, which also kind of complicates the picture. I just wanted to mention that.
You're reading my mind.
on it. She'll figure it out. I'm confident.
Thank you, Kate and Milliman, for your presentation. The intention of this agenda item was to inform and discuss, and I think we've given you a robust discussion. And I just want to call out how cool all you guys are, because you spoke to the data, but you spoke to the people, and the concern was what's going to happen to the people when we explode this thing. So yay, thank you for keeping your humanity.
Well, thank you very much for having us. We are going to drop off the call now, but we'll stay tuned for what happens the rest of the meeting and look forward to hearing any further comments.
Thank you so much.
All right. Thank you.
Thank you.
Great.
Bye.
All right, team, we'll plow forward. If Policy Advisor Hastings is ready, shoot, designating regions, go for it.
All right. Yes, so we've just talked a little bit about those regions, and previously this committee had a proposal about kind of what those regional hubs would be responsible for, and there was a request made for, what are these regions actually going to look like? So just as a recap, in that proposal, we had discussed, or recommended rather, that there would be 5 to 9 non-overlapping regions, and to the extent possible, alignment with existing boundaries. So what we're really focused on is that bolded piece, which is what additional criteria for defining regions, and we have 3 proposals for your consideration. Next slide. So to start with, one of the factors that we really wanted to get some data and some information around was population size. Essentially, what is kind of the minimum population size in order to have a certain kind of credibility, in order to be able to do some of that health resource planning, and essentially for it to make sense, for it to be kind of its own independent region. So looking at a couple different sources, when you look at Dartmouth Atlas Hospital Referral Regions, which are used by Medicare, they have a minimum size of 120,000 recipients within an area, so that was kind of a starting point. If you look at sort of how global health system analysis tends to be done, they tend to work in a 250 kind of range. And then studies regarding just kind of the economies of scale that you can achieve with public health suggest that you really need at least 100,000 individuals to kind of have the best results in terms of consolidating those resources and having a really sort of focused approach together. So based on this, we approached the various proposals that we put together with this target population of 250,000 persons per region, with the expectation that there would likely be 1 or potentially more frontier regions, simply due to the kind of geography and density of Oregon, that will probably fall below that, but as much as possible, trying to hit that 250. Next slide. The next consideration beyond population was really about sort of size and grouping that region. So those boundaries and that distance. We knew that we wanted alignment with referral patterns and transportation corridors. That was part of what was in that earlier proposal, was to align as much as possible with the emergency care designations. We also know that those county designations are extremely common for defining public health jurisdiction, as well as a lot of mental health functions. A lot of, behavioral health grants are actually even done at the county level. Wanted to consider travel time for care. So again, really thinking about what are those transportation corridors, what sort of logically makes sense, and consider political balance, especially regarding the Portland metro region. We know that there's a pretty heavy weighting of Portland as compared to the rest of the state. So trying to mitigate that as much as possible. So considering all of this, the next kind of big framing criteria for developing the proposals was that the regions would follow those county boundaries in order to align with local public health authority, as well as county mental health funding, not wanting to really interfere with that. Then, of course, the caveat that for tribal governments, they might span across regions, and that's absolutely fine. They would be able to participate in whatever way made sense to them. Next slide. And then before we dive into those proposals, just noting these are some of our existing regional health models. Did not include CCOs because I know folks have strong opinions on that, and that's not really what we're going for in terms of having the non-overlapping, et cetera. But looking at the emergency preparedness and sort of public health, it's really more around the emergency preparedness kind of blocks there. These are used for coordinating regions to some extent in a certain kind of resource sharing. They are county-based, which does align with our criteria. They don't really align very well with primary care or behavioral health coordination, though. The next is this Regional Health Equity Coalition. And before you ask what is going on with that crazy brown colored region, all the ones that are colored brown are not actually part of a coalition. So you're really looking at those that have the same color. That really indicates those counties next to each other that do have collaborative relationships in a really strong sort of public health kind of way, public health and more primary care. And this again reflects county collaboration in a really direct way, and what I would term social geography as well. These tend to be counties that have certain social elements in common that make sense for them to work together. And then the final one is our trauma areas, and these most strongly follow referral patterns, particularly those for emergency medicine. So if you're looking at emergency transport or hospital-based care, these are the regions that make sense. They don't perfectly follow county lines, and as you can see, there's a pretty strong alignment to the transportation corridors, which, given emergency care, you would expect that. Next slide, please. So just a quick overview, looking at the criteria that we set on, as well as existing models, there are three potential approaches here. The first one I call sort of the public health approach. This one is really looking at those collaborations that currently exist today. And these are voluntary collaborations between counties. It really strongly considers, again, that social geography aspect of which counties, have these partnerships, have similarities, tend to group themselves together. And it does, to some extent, have some rough alignment with trauma and EMS referral patterns, but it's not really bound by that. It also does consider population much more than the other two models. Option B, I would call our trauma-anchored model. This one relies very heavily on the trauma referral regions. So looking at those 7 regions and transportation corridors, this one is really strong if you're concerned with, again, hospital emergency care, and you really want to prioritize those referral patterns as part of how you're doing your healthcare regions. And then option C, we've heard through public comments over and over concern about things being too complicated. So this is the macro model. This essentially goes to the simplest level. So we'd suggested 5 to 9 regions. This has 5 regions, so really the smallest number. And this kind of serves a lot of different purposes in terms of being the simplest administratively, the simplest to sort of explain to others. And it really prioritizes having the administrative, simplification. Next slide, please. All right, so here we get into some of the nitty-gritty here. Option A, what I call the public health model. This has 7 regions. Again, a lot of this text I think I've already talked through, but social geography driven. This one does include those different collaborative relationships that we see in the health equity space. Some rural regions still do cover large areas, as you can see that Eastern Oregon one. That's pretty substantial. And it doesn't exactly follow those trauma and EMS boundaries, though it does mostly endeavor to. And I would say that this model is really best if you're prioritizing county-based resources, public health, and behavioral health, because you've got that really strong alignment there. And next slide, this is just going to break down in a little more detail sort of what these regions look like. And I think the key thing to note here is As you look across the population, you, of course, the metro area is always going to have a substantially larger population, but we are above that 250,000 threshold in all except for that Eastern Oregon region. And even that is, it's doing all right. It's not in a danger zone, I would say. It's at 190,000. So in terms of population, it looks pretty good. And you can see some of the other just information there in terms of where those hubs might be, how it aligns with public health, which, given that that's what this model is based on, is pretty strong for all of them, and how it fits with those trauma referral regions as well. We'll go ahead and move on to option B. So this is our trauma anchored model based very strongly around those trauma current regions. What I've done is just toggle them very slightly so that they match the county lines here, but otherwise it is more or less an equal fit. So again, this is a recognized structure among hospitals, EMS, and emergency managers. The boundaries do reflect real clinical interactions, mostly at a higher acuity level, but that's still extremely important. Some things to note, though, some of these trauma regions are really small in population, and some of them are really enormous geographically. It's also a bit less intuitive if you are explaining this to the public, to have some of these as regions. So again, this model is really great if your goal is that emergency medical coordination and hospital referrals are going to be prioritized. And next slide, let's dive into the details here. So as we look specifically at these regions, the red are ones that I consider pretty concerning that would probably need to be addressed. Orange are just kind of worth noting. So again, that metro region, pretty large. It's a bit larger than the other one because instead of just the tri-county area, this model does include 6 counties. So the North Shore kind of gets lumped in there. Southern Oregon, there is this 2-county region, which is pretty small geographically, although size-wise, as you can see, it does okay. However, up in the gorge, we do have one with a really tiny population that really is not sustainable in terms of some of those other standards that we looked at for what makes sense in terms of public health working together, and even the Dartmouth Atlas size, this falls well below that. And Eastern Oregon, we know that that region is probably always going to fall below the 250,000, but here, once again, it does. So you can see that public health alignment kind of ranges in the medium zone for a lot of them. A couple of them are low because of that small size, either geographically or in terms of population, but those trauma and referral regions are basically a perfect fit. All right, next slide. So option C, this is our macro model, our simple model, easy to understand, easy to explain. Of course, the challenge whenever you go with something macro is that the regions do become much larger and therefore more diverse, less representative of what makes a particular area unique. And so there is the potential to lose some of that nuance with these. But this is best if you want to prioritize simplicity and low administrative burden. Next slide. So what I would say is the real challenge with this is you end up with 2 pretty large regions, and then that, again, somewhat small Eastern Oregon region. So that metro area becomes extremely large under this model because it ends up grouping both Portland and Salem together. And then that South Valley and Coast area is nearly 1 million people. So you end up with, I don't know, was that like 2/3 of Oregon's population in just 2 of these regions, which is a little bit of a skew. And as you can see, those trauma and referral fits, it's kind of a weird blend. You get a lot of hybrid areas, so it's it's definitely an option, but there are some kind of downsides to it, I would say, in terms of whether the balance is maybe right. Next slide. And just by way of quick summary, because that was like a whole lot of information and detail, I realize, So I wanted to put together this quick summary of what those options look like. We've got, 7, and 5 different regions. This is how I would judge them in terms of, the population balance, whether they're operationally complex, that EMS alignment, of course, collaborative alignment. So based on those relationships we know they have, and then some of the key pros and cons of the different regions. They all have pros and they all have cons. So it really comes down to what you think the Universal Health Plan should be prioritizing from these regions. I'll go ahead and move forward and turn it over to you, Chair Richardson.
Questions, discussion. Thank you, Lee, for this presentation. I really appreciate the clarity and the simplicity of having 3 models and calling out some strengths and weaknesses for consideration of each of these 3 models. If I may ask, one question that comes to mind specifically with the macro model, I'm thinking there may be the option of dividing even that region C into C1 and C2, so you have Portland and Salem in 2 separate regions, and then otherwise preserving the macro model. Is that possible with these proposed models?
Absolutely. Yeah, I should just say these, I know we have decide on the agenda, but to the extent that there's an option that folks want to see slightly jigger, that's perfectly easy for me to whip up. So I can do that.
Thank you. Lori, what thoughts come to mind?
My thoughts are, number one, that universal health care, we will hopefully have more focus on prevention and less on emergency care. So I think my priorities would probably align more with public health and equity. And the piece about already having regions established might make it also a more comfortable sell to those areas because they've already kind of adjusted to themselves as regions.
Thank you. Other thoughts? Yeah, Anne. Oh, you're on mute.
I agree with Lori. When we talk about quality and we talk about population health, then public health is a natural fit. And one question I had was, what is the current percentage of hospital admissions that are ER? Because in previous hospitals I've worked in that percentage was relatively low.
Thank you for that comment. I don't know if we have that data right offhand.
I know, I'm sorry, Anne, could you elaborate? Are you asking the number of direct admissions to the hospital versus admissions through the emergency department? Was that your question?
Yeah, if you're looking at a trauma anchored model, and there's a very low percentage of hospital admissions that are trauma, then that's a model that from the data
I see
not
your
as
question.
convincing.
Yes.
I mean, I'm totally in favor of public health. I'm just asking a random side question.
We love random side questions.
Oh, Mike, your hand popped up. Did you have a question or comment?
Yes, but I definitely appreciate Ann and Lori's comments. I have a perspective on the criteria thing that I really enjoyed Lee's description here, and that is, even with these regions, I suspect nothing really gets at all the different local nuances. And let me give you an example. I mean, before we had some dialogue, and I wanted to listen rather than putting my 2 cents in, but I live most of the time out on the Oregon coast, out in the Tillamook area, and as the former health director out there, there are nuances up and down the Oregon coast. There are nuances in so many different communities. I think as long as we're clear that there will be trade-offs in any one of these regions, I think it's up to the future administration of this plan to figure out the different nuances. So in different years, there may be different nuances. As an example, this week, if you're in an area where there's a lot of flooding, and I happen to have been a health director out in Tillamook when we had some major floods and we could not literally transport people, you become very focused on that. And so that becomes more important than any other variable. And then you go through 15 years where fortunately we didn't have any crises, if you will. I'm just, I want to temper our conversation with there will be new situations that we cannot literally plan and anticipate. And I also, like the previous speakers, I also believe that we have to be much more activists in terms of prevention, nutrition, public health, and not gear things merely because we happen to have the EMS system organized in such a way. So I support the last two comments.
Thank you. So I've heard some support for the regions divided along the lines of the public health regional model. Are there other preferences or considerations? Are we at a point where we can draw some consensus? Yeah, Sarah.
Yes, I'm not drawn to option B. Option A seems very strong. And that's probably what I'm most drawn to. But I was intrigued when Judy talked about the possibility of 6 regions, kind of an adapted option C, possibly. 6 does sound possibly better than 7. And whatever we decide on, if we could kind of maybe pull over any of the strengths of the other 2 models to slightly adapt whichever one we settle on, that might be good.
I will just comment that with my clinician's hat on, I'm thinking of referral patterns. Although, yes, we do hope that members will not use the ER quite as much. Clinicians are going to refer where they're referring to. And so while the financial model will be a heavy lift to change, it is really hard to change referral patterns. And so folks who are currently practicing now are going to keep referring to the people that they know provide good care. And so if we can divide along at least generally those lines and create the least amount of disruption in that domain, I think we're better off for it. And none of these really are totally different than normal referral patterns. And so I think that basically, folks are going to keep referring to the hospital that they're used to referring to, and specialists at the quaternary care center that they're used to talking to. Not that it matters, right? Because in the plan design, we've said that patients can get care anywhere they are comfortable getting care. However, that being said, we hope that they'll find medical homes near where they live and receive care close to home, ideally, which would be the most economically efficient for them in the system. Oh, thanks. Mimi's put some data in the chat.
Thank you, Mimi.
Nice. Anyone object to number 1, coming to consensus, and number 2, option A, public health? Or Sarah, would you like us to think about and develop even more that macro C1 idea? It's very similar. Hi, Doris.
Hello. So I am leaning more towards option C. However, just to simplify it, the red shaded area on the far top, I wonder if that could be either expanded similar to option B, or Yeah, actually, I think that might just be better to expand the red area to similar to trauma anchored. Just due to referrals and everything, I think a lot of people love being very close and near to each other. I work down here in Coos and Curry, and for those who don't have accessibility in Curry, they just pop over to Coos. And I think that might just be, I'm trying to keep in mind people's travel ability and finances and all that. And that's why none of these options truly fit what I envision, but option C is really close.
Great, Mimi.
I just if I wanted to call out and definitely Doris, I really appreciate what you're saying. I want to call out that these regions are definitely, as we said, they have nothing to do with where people can get their care. They can get their care anywhere. And it is more, if we think of, okay, our groups of providers, if we're going to provide provider education or member education, are they somewhat similar in circumstances? Do they kind of see the same types of people maybe? Or if if that's what you are focusing on, or is this a region that is known to collaborate and they've done lots of innovative projects already together? And I definitely do appreciate though the challenges with the very, very large population, because then and we know that's going to be a problem in the Portland metro area and even in the valley. But just to make sure that everyone's clear that absolutely people will 100% be able to bop over to another county. It does not limit them. That's what I'm really trying to get at. It doesn't limit patients in any way from seeking care anywhere.
Thank you for that clarity. Lori.
So a couple of questions. One is, if we look at hospital beds, the numbers per each region, organizing the regions in a way that would not compromise, if over time there will be, even though we can use anything anywhere, there'll be some natural selection based probably on how the regions are created. And I guess the other thing that I consider extremely important is sellability. We're really making a huge change for patients, and I really think we need to consider what they're familiar and comfortable with currently, rather than just moving borders for our own personal focus.
Thank you, Lori. I have a proposal for the group, and Mimi and Lee keep me in the coloring in the lines if this is inappropriate. But what I would like to do is table a decision about this to our next meeting, knowing that we've had such rich conversation now. If it tickles more questions, or if you want to see the risks and benefits, the pros and cons of each one again, I feel like we're consolidating around the number of regions fairly well, being 5 to 7. And you can correct me if I'm wrong too, but my proposal is to give us some time to really think about this and then come prepared to make a decision at our next meeting. How does everyone feel about that? Is that okay? That doesn't put us behind the 8 ball, Mimi, for our work plan at all. Oh, hi, Sarah and Anne. Go ahead, Sarah.
I would be comfortable going with A if you were pushing us for a decision today, if you're interested in consensus.
Mimi, what is it that you need from the committee today about this topic?
Well, what we hope to do is during the presentation to the board about what's happening at Operations Committee is, again, just as everyone likes to have iterative processes. So if we could give the board, and we can do this, that we can say, well, they weren't quite ready to make a decision, but if we may, say that they're leaning towards option A. And this is the rationale, and then there are some other things for consideration. That's also apparent. Yes, I do. I am sort of working on people to start being ready to make some commitments. And again, these are recommendations to the board, which will include, can include their caveats too. It's not like this is set in stone by any stretch of the imagination.
Thank you. I like continuing our reputation as being thoughtful and deliberative. Sarah.
Yes, I feel like the presentation was very detailed. Thank you, Lee. And I don't think that my mind would change any with a month more to deliberate.
Definitely, you are welcome to make a motion. I won't discourage a decision.
Anne.
Yeah, I move that we adopt the public health view with the understanding that some of the details may shift it just a little bit, because there were some good comments about the other models that could certainly be adapted.
Great motion. Thank you, Anne. So there's been a motion to recommend option A, the regional distribution and boundaries based on the public health distribution. Is there a second? Oh, Sarah is seconding. Any discussion about this motion? Isabel, would you do a roll call vote for us?
Absolutely. Bruce Goldberg is on leave. Judy Richardson,
Yes.
Mike Leahy,
A weak yes. I still would appreciate a little bit more thoughtfulness, and when we get down to talking about costs, if you will, that's a factor. But having, but otherwise, I agree. I agree with a lot of the elements of the public health piece.
great. Laura Byerly is not here today. Doug Flo, I see your hand up.
You're on mute, Doug.
Pardon me. Yes, I would say yes. I would concur.
Thank you, Doug.
Thank you. Sarah Fouché,
Yes, and I'd love to hear possibly more about why Doris thought C was better, and maybe we can find a way to incorporate that.
Maybe after the vote, we can have an amendment. So we'll keep going through the vote, Isabel.
Lori Hoagland,
Yes.
Michael Hoare is not here. Doris Karagu,
Similar to Mike, mine is a weak yes.
thank you.
And
And love, oh, go ahead.
I just need more time. I know this was presented to us, but I think I just need more time. But for now, weak yes.
Anne Lovejoy,
Yes.
Paula Weldon,
Yes.
thank you. That's everyone.
Thanks, Isabel. Sarah, further discussion or an amendment to the recommendation? Yeah.
No, since Doris said that she needs more time, I'd love to hear her comments next time, or when she's come to any articulations about what strengths she sees in C. Yeah.
That's great. Yeah, this is not immutable law. It's, do we have a consensus? And I would have done fist to five, but it's kind of hard to do that on the screen. So thank you, Isabel, for calling a roll call. And all committee members, it's okay to vote no. It's okay to vote abstain. And it's okay to say, hey, Judy, I'm not ready to vote. Let's hold off on this. All of that is okay. We'll still be friends. But just to keep things efficient and just make your vote. Yes, we will have a break right now. Thank you, everyone. Let's take 10 minutes and come back. Okay, everyone, as we come back together, thank you, Lori, for reminding us the importance of a break and a shakeout and a bio break and all of the above. And I hope you had more than just other work to do for a break. As we look to our agenda, the next item was subrogation, which I proposed to the committee to table this topic. It was a presentation by Lee about subrogation and what that is and why we care as an insurance entity. But let's push that to our next meeting if we will. I would really like to get to our discussion about eligibility and enrollment and come to a decision about that to kick that over to the board. And if we have time, we can talk a bit about how insurance companies get claims from responsible parties. But if that's all right with everyone, let's proceed to number 6, Lee. Great.
All right. And of the eligibility and enrollment, we're really focusing today just on the enrollment piece. Next slide. And specifically, there are kind of 3 topics for discussion. There's enrollment for new members, what that process looks like, re-enrollment processes, and enrollment verification. So what kind of documents we're really looking for. And that's really initial enrollment that we're talking about that verification process for. All right, next slide. So we did discuss essentially new enrollment or enrollment for new members a bit last time. And here's a summary of some of those options that we talked about. We mentioned immediate enrollment just as kind of a simple, you're in and you get full benefits, and that's, that's the whole story. We talked about one where there was a limited window in which you needed to apply with some retroactive liability if you didn't sign up in time. We talked about an option where initially you got, primary care and emergency benefits, but you had to wait to get some of those additional elective type things as part of your coverage. We talked about options for credible coverage, so those coming from other state or federally funded healthcare programs, essentially being in kind of the express lane for that, and then a tenure, a residency-based tenure. And this is something that could be sort of like C in terms of being related to benefits, or it could be related to cost sharing, or it could be any number of things, really, but something that would come into play after someone had demonstrated longer term residency in the state. All right, next slide, please. So as I was thinking about this in between meetings, this made a lot of sense to me. Hopefully it makes sense to the rest of you, but in terms of kind of a decision as far as, walking through and figuring out what made sense, this is kind of what I came up with. At the top, we have simple enrollment, and this is enrollment where, you're at the 100% benefit level, it's available immediately, and you provide your full verification within 90 days. But from the day that you show up and say, yes, I am an Oregon resident, or I live or intend to live in Oregon, you would be eligible. So that's kind of our baseline. Now on the far left, you can see the option for just sticking with simple only, just saying, I don't want to complicate it all. But for folks that are interested in looking at some of the different levers that can be applied, there are a couple initial ones. The first would be a new member waiting period. And this would be akin to that option C that we discussed, where you get those primary and emergency care services available immediately, and additional services would kick in maybe at 6 months. And of course, there would be some provisions in here for folks that had certain conditions or needed chronic care, etc. But in general, you would really be waiting at least 6 months before you got that full coverage amount. The other easy addition to simple enrollment is to require a verification prior to enrollment. So under our simple enrollment, you can essentially do an attestation and you're covered for 90 days. And you have those 90 days to provide your full information. But one of the wrinkles that we could put in is saying, we're not going to provide a 90-day grace period. Instead, we would like to see that verification in advance. So you might move to the state, and you might have a brief window of being uninsured, at least under the state health plan. Under each of those, you can do more refinements. So that new member waiting period, you can have that be the full covered services or that longer term residency benefit. So we're looking at, previously what we discussed is option C or E there. For the verification prior to enrollment, really the one wrinkle there is that you have to have an exception for anybody who is Medicaid eligible. I would imagine Medicare to the extent that that's part of the plan as well. So you'd really be looking at folks that are not already eligible under some other federally funded healthcare program. So I don't know if you want to pause for discussion here or save kind of all three of them for the end.
Lori.
If you had a new member waiting period, at less than 6 months, that seems like, in some cases with cancer or orthopedic injuries, that could be a problem. So just, that's my comment. Maybe that with a shorter duration.
Go ahead, Anne.
Yeah, one of the process improvement principles is not to allow paperwork to cross a boundary, because so what that would mean is verification prior to enrollment really cuts down on administrative churn, because the paperwork only goes through once. Whereas if you allow people to opt in or opt out or to flow back and forth, or you're asking for paperwork, asking for paperwork, asking for paperwork, that's a high administrative burden. So if you set this up as the policy, we will ensure you as soon as verification is received. That dramatically improves process.
Thank you, Anne. Go ahead and keep going, Lee.
All right, thank you so much for the thoughts. Next slide. So moving on to our next process. So what we'd really discussed there, that's for new members of the plan. So essentially people that are moving into the state of Oregon. Re-enrollment, as much as possible, this should be an automatic process. The idea is this is something that would happen annually. The primary mechanism that we propose would be filing that Oregon personal income tax. So filing that tax return or being claimed as a dependent on a tax return, that would be that immediate sign that, yes, you continue to be a resident within the state, and absolutely no separate information would be required of you. Your coverage would automatically be extended for the next plan year. And I wrote, unless there's an opt-out. I don't know if that's going to be possible, but I just threw it in there in case. Having this as the primary mechanism is estimated to capture somewhere between 75 and 85% of eligible individuals. So we're getting a really, really good number of people just automatically with this mechanism. Secondary mechanism, participation in verified state programs. And I realized after I submitted the slides, I should have said state and federal programs, because I did mean to include Medicare in here as well. But doing certain checks for those that did not file a tax return for their participation in other programs that do require annual or periodic residency, such as SNAP, TANF, Medicaid, and state-funded long-term health programs. I think also then at this point you could add a simple 65 plus, at which point they are presumed to be Medicare eligible, and they would also be wrapped into this. And so if an individual is in any of those qualifying programs within the past year, they would also be automatically re-enrolled. No separate request or information. All of this would be seamless to the individual. They would not even know this was happening. These two mechanisms are estimated to capture about 90 to 95% of all eligible individuals. Next slide, please. All right, and then kind of our tertiary mechanism, and really this is sort of two steps. Kind of for 3A, we're doing what is called the ex parte logic, which is something that is used by Medicaid. This is they're checking all available public resources, essentially. So still trying to get that verification without having to directly involve the individual, trying to make it as seamless, as smooth, as easy as possible before they do any outreach to the member. Assuming that doesn't work, there would then be outreach to the last known contact channels, such as address, employer, any other information that's available. And then it is proposed to include a 90-day grace period in which coverage continues unless the state receives some contrary information. And then, of course, if there is still no verification, it would lapse at the end of that period of time. All right, next slide. All right, and then kind of our third topic around enrollment here is verification. And we're talking about that initial verification. And the goal is very much the same as kind of what we just saw in the re-enrollment. It's to make this as easy as possible for folks. We really just want to collect the information that's needed to establish that they are validly eligible for coverage and to align with any federal rules or any kind of matching requirements. So this was something that we actually did discuss last time, but there's really just 3 buckets of information that I would propose are needed. Residency or the intent to reside. This, of course, is the foundation of our eligibility. The second one would be income, and this is necessary as part of obtaining federal matching funds. So a little bit contingent on what happens with that Medicaid population and how that's involved. But assuming that Medicaid is an element of a universal health plan, we would want to make sure that we have that income information for that reason. And then finally, identity. And I would say this is really for that Medicare eligibility piece to the extent that they are a US citizen and age 65 or older. We know that, again, they have that coverage. And depending on how that population's involved, there might be a matching, there might be some different benefits required for those individuals. So similar to the income for the Medicaid folks, there could be some special rules, and we want to make sure that that is designated. And next slide, these are some proposed items that would achieve this information. So as you can see, there's a lot under residency or intent to reside. The goal is you would just need one of those. Maybe 2, depending on how valid it was seen to be, but that there could be a lot of options for establishing that residency requirement. For income, of course, there's the verification, and there's also the possibility that no income data could be required for those that attest to being very clearly over the Medicaid thresholds, just to kind of keep in line with collecting the minimum amount of information necessary. That might be something worth exploring if that's possible or if that makes sense. And then for identity, really looking for that name, date of birth, any kind of alternative ID information, and yeah, that general contact information. I think I just threw that in for the notices, et cetera, but also important information just to have associated with the account. And next slide. And that is it. I will turn it back to you, Chair.
Great. Thank you so much, Lee. Hopefully this material was not new to the committee. We've seen, we've had this discussion before about enrollment and eligibility. Lori, what are your thoughts?
Undocumented residents of the state. And, imagining we're going to be in a different world than we are at the moment. But how do we care for people who are in that category?
Yes, and how do we cover providers who are providing care for those folks? They're going to show up in the ER and then the hospital is out because no one wants to pay for the care. I was also thinking about a homeless population. We could probably do some fact finding, to Mimi's phrase, about what the magnitude is perhaps in the state. How big of a bucket is that? And is there an alternative support? Thanks, Mimi. Hi.
Hi, not so much the actual number, but I think one of the key components of the plan that has really been discussed a lot in plan design and eligibility is that living in Oregon is all that you need. It does not matter your status as a citizen or a non-citizen or papers or no papers. So I think to Lee's point at the beginning, that it's what you would be looking for is that residency status. So where people are living now, obviously folks who are in a houseless population and that population, there are workarounds for that and ways to establish a region, an area, or city, what have you. So there, I think there's a lot of workarounds. But in terms of will that population of people be covered by the universal health plan, the answer is a resounding yes. And it's just how to bring about some verification, just that they are indeed intending to reside in Oregon. I think I'm just going to toss one other thing in here, which was something that was brought up by Milliman when they were talking to this about us. They said, well, so is everyone going to get a card, like a physical card, an ID, but I think to the point is, will everyone have a unique identifier, which is something when we think about electronic medical records and what the capabilities in some other countries that they have, where literally someone's entire medical record is available. So I don't have an answer to that. I'm just tossing that out there. Sorry, hopefully it doesn't necessarily need to add a wrinkle into today's discussion.
Thank you, Mimi. I was thinking about that too, and I was really surprised to hear the administrative cost of printing cards, printing member cards. Just like, oh, I'd never thought about that before. And there are places in the UK that don't have a card. They have you have a number, but you don't have a card. Other thoughts or discussion? And since this is an item for decision, I will entertain motions to support one of the three models. Lori.
I'm not ready for a motion, but I think the one where you look at all of the possible records and not requiring someone. Think about people with mental health illness and the idea of taxes, or being organized enough to get the pieces together to get their care might be too much. And so I think the less that the person has to do, the better.
Yeah. Other thoughts, questions, comments, concerns? Go ahead.
The other thing, thinking about Anne's comment of having some form of identification at sign up, is in the event of someone being in the state prior to having that confirmation of residency, if there was some way that a person could, not be uninsured and not be able to receive care, if that could be built in, an exception.
And I'll take responsibility for skipping over subrogation, but the idea may be that if someone comes from another state and they carry with them their current insurance plan, before putting them on the Oregon Universal Health Plan, we make sure we get money from Idaho Blue Cross or whoever it is that they carry, right, until they do qualify for residency. Good discussion. Hi, Paula. Haven't heard from you this afternoon.
So this is like when we're in full operation, right? I was thinking about dependents, and it's so the auto enroll and all of that is really based off of what would be a policyholder in the commercial side of things, right? For dependents, but we would how would that work?
How would dependents be enrolled? Is that what you're asking?
That just.
Lee, do you want to answer that question? I imagine you think you're on the right track, Paula, but go ahead, Lee.
Yeah, the idea is if you are claimed as a dependent on someone's personal tax return, you would be covered per that filing.
Okay. Through the tax return for that particular person. Okay.
Sarah.
Are we supposed to discuss or consider what we think about the waiting period?
Sure.
Is no waiting period and a waiting period, are those both on the table?
Mm-hmm.
Yeah. I like the idea of some kind of waiting period for the purposes of our budget, mainly.
So waiting period and verification prior to enrollment would kind of be effectively similar. They're not the no waiting period. You can enroll immediately, and then we figure out verification later. So both of those, I think, would fall under that bucket.
Yeah. Yeah, I'm in favor of verification prior to enrollment, but once they bring in the verification, they're insured.
Mm-hmm. Doris.
Actually, I have nothing to add. I agree with Anne Lovejoy. I think after the verification, they should just be enrolled.
Other thoughts? Would anyone like to make a motion that we can do a vote on, a roll call vote? Lori.
I'm not quite ready for the motion, but with people who are, for instance, winter snow bunny is there any comment about how long you have to live in the state? I know taxes, sometimes that's already spelled out to be considered a resident.
What is it for tax purposes? Is there a minimum number of?
Yeah, Oregon has to be your domicile, or you have to spend 200 or more days of the year in the state.
So we could align with that.
That's what our current eligibility proposal says.
Great.
So that could be changed, but that's what it stands at now.
Mike.
This is not from my perspective, but my wife has been a tax accountant for the last 30 years, and she's described to me there are large numbers of people that essentially are what we might you call snowbirds or whatever, and many of them very deliberately, let's say, as a case, I'm talking here about how this will ultimately affect adverse selection. There are lots of people that, as long as they can claim, let's take a state like Arizona, to be there 6 months in one day, they can pay primarily Arizona tax rate as opposed to Oregon. If we envision we will have an additional tax, we will probably have more examples of that, and that leads to a corollary point, which is adverse selection. If you have groups are used to, as you employ somebody, you don't get the coverage until the following month or 3 months later or whatever. If we don't do that, actuarially, we will have a certain amount of adverse selection. So at least it would be important to understand what's the financial impact of that, and however wonderful it is to give everybody everything initially, at some point we'll need to understand what's the fiscal ramification of that. I think if it's minor, none of us will be concerned. If it's a significant deal, we may want to revisit this.
Thank you for the comment, and maybe Mimi's going to say the same thing, but if under verification, health coverage status would follow your tax filing status, so they would have to make the choice. Mimi.
I was just going to add that Milligan consultant group, sort of on the plan design and expenditure arena, has definitely built into their calculations that adverse selection proposition. So I think that, I mean, it's an excellent point, and it's a real thing. So
it's a real insurance thing. Sarah.
Yes, Judy, I appreciate your invitation for us to always feel comfortable voting no. If, for example, 5 people voted yes on X motion and 2 people voted no, how does that, what happens next? We're not operating on consensus only, I believe, and so then the board hears, you know, such and such a straw proposal had a vote of 5-2, and then the objections kind of maybe get summarized. Is that how that works?
Absolutely. That would be my intention in communicating with the board, because these are recommendations and they actually want to hear if there was like a uniformity in opinion or lots of different opinions, because then they're the ultimate decision maker. Our role as the committee is to provide our best recommendations. And so as rich and diverse as those can be, I think they appreciate having that and weighing it appropriately. So, yeah. So if we're to that point, we could have that kind of a consensus vote and capture in the discussion. I don't want to say dissenting opinion. It sounds like such a subversive term, but different opinions that do not agree or align with the consensus. Is everyone feeling comfortable doing that at this point, or do you need more data or information to make an informed recommendation? Sarah.
I'm just a little muddy on what we might be heading towards deciding.
Lee, would you bring up the slide again that talks about the 3 models?
Yes. And I think part of the confusion might be my fault. There's sort of 2 different ideas here. The first is enrollment of new members, and then the second is a proposal around re-enrollment. So there's sort of 2 different questions out there.
And sorry, I'm just going to add in there too that you certainly could say, I'm just going to make a motion and just limit it to verification prior to enrollment. It doesn't have to be the whole enchilada. It can be one specific component of it, and then people could say, yes, we all agree that that's a great idea, and we're going to go with that. And then there could be potentially another motion about a member waiting period or what have you.
Does anyone feel so inclined? And if not, that's okay too. I just want to give appropriate amount of time to noodle and articulate.
Regarding this slide hierarchy of enrollment option, I support the verification and then enrollment.
Thank you, Doris. Would anyone else like to second that?
I'll second it.
Okay, Anne. Isabel, would you go ahead and call a vote? And everyone feel free to vote how you feel, and we will capture in the discussions additional comments.
Yes. Okay. Bruce is absent. Judy Richardson.
Yes.
Mike Leahy.
Yes.
Laura Byerly is absent. Doug Flo. Doug, I didn't hear you if you're able to voice your vote.
Wonder if he may have stepped away for a moment.
Okay.
Oh,
Doug,
was that you, Doug?
What was the last name? I'm sorry. Was that Doug?
That's you.
Yes.
Thank you. Sarah Fouché.
A week, yes. I'm sorry, I'm not quite clear whether voting yes on this means we're pretty much ruling out a new member waiting period for now, but after we finish the vote, somebody can answer that, maybe. Thanks.
Thank you, Lori Hoagland.
I would say a week, yes, with some kind of caveat personally that under dire circumstances, there could be considerations for people.
Thank you. Michael Jorge is not here. Doris Karagu.
I already voted.
And
Yes.
Lovejoy. Yeah.
Yes.
Thank you. And Paula Weldon.
Yes.
Thank you. That's everyone.
So that sounded pretty strong as far as consensus. Please, for you weak yeses, say more about that so we can capture it for the board.
I'm sorry, I'm a little bit in the dark about how this slide works. So there's a hierarchy from simple. Can you just talk me through the big picture of what we just voted on versus what else is on this slide?
Judy, would you like to take that?
Take it away, Lee. Go ahead.
Okay.
Sure, Scott.
Sorry, this is clearly how my head works. So I started with the premise of, at the highest level, you've got a really simple kind of enrollment. And then you can start to break it down into these two pieces. So the way I see it, whether you do verification prior to enrollment and whether there's a new member waiting period, you can have one of those, you can have both of those, or you can have neither of those. Because the new member waiting period is about, okay, once you're enrolled, do you have access to 100% of the covered benefits or not? Verification prior to enrollment is just about when are you enrolled? Can you do a soft attestation to get coverage, or do you have to have full documentation and then you're enrolled? So those two, they can work in tandem, or you could just choose one of them.
And so, Sarah, what this gets to is that issue of adverse selection. So people won't come into the state and get really expensive care immediately because they've gone, even if they've gone through verification, there's a waiting period before they can get more expensive care. Go ahead.
I guess I'd like to either ask for a fist to 5 on the new member waiting period or like a yes or no vote so I understand like what the tone of the room is.
Sure, we can totally do that. Looking at the slide, it's almost easier to call names, but I don't want anyone to feel it's like more formal or binding. It's just easier to get consensus that way. I like fist to 5. It's easy in the room. Sarah?
And then I think it was maybe Lori who talked a little about like a modification to what we see on the slide with the new member waiting period. And she wasn't maybe crazy about the 6 months. And then you brought up some other, so there's like also just what's on the slide versus like a modified version kind of floating.
What's up? Yeah, go ahead, Lori.
So I guess I kind of feel torn in two different directions. One is that I realize that partly getting people enthusiastic about this plan is not having it be too easy to get because Oregonians would be concerned about people, maybe bumping them out of care so that people can rush to the state to get care. And affecting the health system in other ways if we make it too easy. At the same time, with my background working on a mobile health unit, I know that you want to eliminate barriers and things happen to people. People sometimes are traveling through the state, they get in a major accident, they end up staying in Oregon for 5 years because they can't afford to deal with the consequences of that accident. So, I think that you just have to build in some flexibility.
Anne.
So Lori, are you suggesting that for emergencies, that there's a special policy that people could petition for enrollment based on that?
Yeah, yeah. That there could be a circumstance where I mean, we probably assume that many of these individuals might be Medicaid eligible, and that's why they didn't already have a pre-existing insurance coverage. But it could be a circumstance where you end up with a very complicated healing and you end up staying in the state for an extended period of time. And you haven't had an opportunity to verify your enrollment initially, but you want that coverage for the major surgery, et cetera, that may have to happen immediately. So there's just people who are going to fall through some cracks, and I think we need to build that flexibility into it. At the same time, I also see some value in having a waiting period, although, like I said, I think things happen to people, and I've just been at the end of many patients waiting because of insurance barriers and having dire consequences as a result of it. So I want people to also be able to get care quicker if they need it.
Thank you, Lori. Mike, I see your hand.
Sure. This is just based on previous experience, and I will tell you that there there are often humane considerations where if you're the health plan manager, you can make an extra contractual exception, if you will. This stuff happens. It's not terribly well understood or organized, but I assure you, it happens, and it's part of our humanity. So in examples like you're all referring. So the issue is, what is the policy? But of course, there will be charitable care and other humane exceptions to this if a public authority did this. So I don't think we have to get into the appeal processes and other things. I think your conversation is getting at the spirit of this, of how much humanity do you want to do, and how much additional adverse selection are you seeking from people who will come into the state? There's no one right answer to this, in my opinion.
Thank you, Mike. Sarah, what are your thoughts?
I'd love to yield to Mimi, but I'd love to be maybe next.
Okay.
Oh gosh, Sarah, thank you. I just wanted to point out, if people weren't able to see it, what Lee Hastings put in the chat again. So Medicaid eligible individuals must be covered immediately per federal law. So if Oregon, which we are planning on doing, is going to accept federal funds for the Medicaid eligible population, they will not have a waiting period. They will not need verification prior to enrollment. Doesn't mean we won't ask for it, but what I'm wondering if people might consider, this is maybe a little watered down, is, and even just sort of to consider the possibility of some type of waiting period. It could be something as simple as that, because another thought would be like, no, absolutely no waiting period at all. So you could sort of think of those two buckets and then sort of take it from there. But definitely in terms of the Medicaid eligible population, they are immediately eligible.
Sarah, go ahead.
Oh, well, I'm heading towards a motion, so I'd like to yield to Anne.
Anne.
Yeah, I was just going to say, if the underlying concern is that poor people are going to flood to the state, there's been all kinds of studies that have shown that actually doesn't happen. In other places with warm weather, for example, that have better coverage, there's always a lot of talk about how, quote unquote, those people will flood here. And in fact, they do not. So if that's one of the underlying concerns, I don't think it's something we need to worry about. Now, that being said, I also don't think I think if someone is verified that they're here, then I'm not in favor of a waiting period, just because it adds extra administrative burden.
Thank you, Anne. Lori, what are your thoughts?
Well, I guess I'm mixed about it because I actually can imagine a population of people who are unhappy with their coverage in other states. They are not impoverished people, but they are open to the idea. They will travel to India or to Korea or wherever for medical tourism. They may be open to the idea of coming to our state for 6 months to have their shoulder repaired. And part of my concern with that is not so much being restrictive in terms of wanting to offer universal health care to everybody, but it's more of a worry about, are we resourced for that? And the people who live in the state should not have to, stand at the back of the line while other people are moving in to get their care and then planning to leave.
It's a great discussion. Paula, what comes to mind?
What is the, so I was thinking about the waiting period, because I like the, primary emergency care available immediately. I think 6 months is too long for a waiting period, but I was wondering what's the idea of when the waiting period starts, so I can see, someone may move here and maybe not sign up yet, and then there's the part about they're getting verified and they're enrolling. Now does this clock start ticking? But they're verified, right? So that's just what I was thinking when I was listening.
Go ahead, Sarah.
Okay, I'd like to move that we recommend a new member waiting period. And part B is that I'd like consultants or someone like Lee to prepare some more in-depth options to flesh this out.
Thank you for that motion. The motion is to recommend a new member waiting period with additional work to be done on that model. Is there a second? If there is no second, what I suggest, oh, Lori, go ahead. Oh, you're mute.
Sarah, are you going to do any verification as part of this motion, or, I'm a little confused.
Well, we voted on verification already separately.
Okay, I'm sorry.
What I would like to do, Sarah, is communicate back to the board that we've had this really rich discussion, that there's general consensus that we want to seek verification prior to enrollment, but there's also this discussion about new member waiting period. What does the board think? What does the board have an inclination based on the principles and priorities of the board, or do they want us to continue to dig down under waiting periods, look at some other models, get some more data, and come up with a second recommendation about that? How does that feel? Is that all right? Honors the idea. Great. Mimi, you got some notes? Yeah, Anne.
Yeah, I just want to say that one of the plan design meetings, they had a discussion on waiting periods as well. So if there's some other input from other work teams, it might be helpful.
I love it. Yes, great point. They're looking at this elephant from the other side. Perfect. Any remaining thoughts or discussion about this topic? We'll certainly bring it to the board and come back here to the committee to talk about what they said. I really appreciate your thoughtfulness. You've challenged me thinking about this issue. And thanks, Lee. Our next agenda item is committee member reflections and next steps. I'd like to reserve a little bit of time for public comment if we have it still at the end. I did hear during this meeting next steps request for future topics from Mike, specifically around the transition planning discussions and operational workforce flow, ebb and flow, as this plan implements. And I would like to devote more time of a future committee meeting and have some data and really talk about how the current state, the proposed future state, and some other ideas from other industries too, when there's been workforce retraining design and how that might work, and the people who will be impacted. Other requests for future next steps or future topics for this committee, we're following our work plan really closely. And thanks for letting me push you on some decision making to push this ball down the road, but I think we're doing well. Lori.
Can we look at the regions from the perspective of what they each are resourced with in terms of hospital beds and other things, just to get a sense of, equality perhaps going into this, knowing that, of course, people can cross those regions, but.
Yes, absolutely. Lee.
Can I just clarify on that point? Would you like to see the regions as proposed, or what I took away as kind of the most interesting ones to this group, option A, and then sort of a 6-region macro version?
I would say the proposed one with
proposed.
A,
Okay.
Yeah.
Okay, thank you.
Thanks, Lee. I love that question. It gets to what did we learn from the COVID pandemic and how do we share resources across regions, because they're not siloed, thankfully. Great. Other reflections? Sarah.
Circling back a little bit to this whole big topic, which was just looking at Lee's slides here. The first page in the enrollment, first slide in the enrollment topic says today's discussion. I don't see a slide number. I'm sorry. Today's discussion, 3 points: enrollment for new members, re-enrollment process, enrollment verification. Besides this, I don't know, kind of sticky subtopic that we got into about a new member waiting period, did we cover the bases, and is the board going to get this whole section, and are we saying that we like the whole idea of this whole section on all those 3 enrollment?
About re-enrollment?
Yeah.
I don't think we really had that discussion about re-enrollment. Sorry. We got stuck on just initial enrollment and new members.
So I'll just jump in to answer, Sarah, your question, kind of what happens at the board level anyway? So because this will have a portion of a proposal, there usually what happens is there's a reiteration, so sort of a Reader's Digest condensed version of the, this one doesn't have a specific written proposal, which sometimes we do, but because it's relatively simplistic. So Lee once again gives an all-star MVP presentation about what has happened, and then Chair Richardson would usually go over the opinions of this committee, what was voted on, topics for further discussion, et cetera. And then at that point, we probably, because there's enough information, that we would ask the board again if they want to, if they agree with the proposal, say in this case for verification prior to enrollment. But again, it's still, yes, we think that is the right direction. Keep moving forward in that way. It's still not set in stone. So that's kind of how it works.
Great. Thank you for the question, Sarah. Yeah. Cool. Do we have any additional public comment, Isabel?
No, we do not.
Okay. Anything else for the good of the order from the committee? Oh, pup. Thank you, everyone, for your thoughtfulness, for your comments, for creating a culture in the committee that is open and welcoming to any sort of idea. I love it, and I appreciate you, and I appreciate your time in these busy days leading up to the winter holidays. If you take a holiday, I wish you health, rest, and rejuvenation. And if you're working, my deepest gratitude, because you're helping others take that, and I hope you take some time for yourself after. See you again soon, friends. Bye-bye.
Thank you.
Thanks, everyone.